All right. Hoping you guys can hear me okay and see the screen. For those who don't know me, I'm Kayla Sheridan. I use she, her pronouns, and I'm continuing our advertisement for the clinician educator track today. I'm going to be talking to you guys about intimate partner violence and specifically recognition of it and screening for it in our clinical context. Now, no financial disclosures here. I do want to note briefly that I'm absolutely not an expert in this topic. It's something that I care about a lot and try to do in my clinical practice, but something that I also wanted to learn more about, which is partly why I wanted to give you guys this talk. Also a content warning quickly. So we're going to be covering some pretty difficult topics today, including physical, emotional, and sexual abuse. And I want to recognize that while we're going to be talking about these in an academic way as they affect our patients, some folks in the room might have some lived experiences with these kinds of violence. So please do whatever you need to do to take care of yourself, opt out at any time. So let's get started. Today, our goals are to define intimate partner violence and recognize some limitations of our current definition, to broaden our current illness scripts for patients experiencing IPV, to recognize validated screening tools for intimate partner violence in our clinical settings, and then to practice some language to use when screening patients for intimate partner violence. Let's start with a case. So you're seeing a 33-year-old woman who's coming into clinic for a wellness visit. She has no known medical problems. She's up to date in her immunizations. She had normal baseline lipids recently and had a normal PAP test 2 years ago. You remember learning something in your immersion block intern year about a recommendation to screen patients for intimate partner violence, but it's not something that you've asked about at a wellness visit before. So where do you start? So let's define our terms first off. The CDC defines intimate partner violence as abuse or aggression that occurs in a romantic relationship between current or former romantic partners. And that includes physical violence, sexual violence, including non-physical sexual acts, stalking, and psychological aggression, which they describe as the use of verbal or nonverbal communication with the intent to harm another person mentally or emotionally or to exert control over them. The WHO pretty similarly defines IPV as any behavior within an intimate relationship that causes physical, psychological, or sexual harm to those in the relationship. I do want to note that while this definition is pretty broad, the WHO actually couches IPV within its larger topic of violence against women specifically. And they specifically state that they do this because the majority of those affected by IPV worldwide are women. Now, I alluded to this just now, but despite the breadth of these official definitions, there are often folks that are left out of our conversations around IPV. This affects the way that we obtain data on these issues, as well as how we promote screening and allocate funding to support survivors of intimate partner violence. An example of this is the way that many state-based domestic violence laws completely leave out queer and trans populations, for example, those in Louisiana. And it's actually only been less than 10 years that the National Violence Against Women Act, which is how we fund these issues, has included LGBTQ populations at all. So who are we screening for intimate partner violence? So you guys are all excellent primary care doctors, and you're probably aware that the USPSTF makes a grade B recommendation that clinicians screen for intimate partner violence. They only recommend screening a pretty narrow population, specifically women of reproductive age for IPV. They report that there's not enough data to support screening for IPV in men or in older women. Screening is recommended, obviously, because IPV is super common in our patients. It's interesting that despite the USPSTF recommendation in the US, intimate partner violence is reported at fairly similar rates in women and men, with 36% of women and 33% of men reporting one or more instances of contact sexual violence, physical violence, or stalking by an intimate partner in their lifetime. This data is from the CDC's National Intimate Partner and Sexual Violence Survey, which is a recurrent sort of data gathering effort accomplished by a phone-based survey, which is most recently done in 2015 and happens about every 5 years. I want to note that the more frequently quoted numbers you'll hear are these ones, that 1 out of 4 women and 1 out of 10 men report IPV. This is actually from the same survey, but specifically refers to people who reported what they call IPV-related impact, which is this sort of complex metric that includes the effect of the violence on participants' safety, their ability to work, their finances, their health and psychological well-being, things like that. You'll see people quote the statistics super frequently without specifying this caveat. And I do think it's an important distinction to know about because this is part of what drives the way that we screen for and combat IPV in a really gender-based way. That initial data doesn't include emotional or psychological violence, but these numbers are pretty much identical. So over a third of women and men experience psychological aggression in their lifetime. This includes what they call expressive aggression, so insults, humiliation, things like that, and then coercive control. So being kept from accessing funds or contacting family and friends, being kept track of, having your activities controlled, or having physical harm threatened. As a further reason to screen, IPV is associated with a really large number of medical conditions and health sequelae. So there's an association of intimate partner violence with chronic problems like asthma, diabetes, cardiovascular disease, as well as a lot of somatic and chronic pain conditions like headaches, fibromyalgia, and chronic abdominal pain. It's also associated with gynecologic issues like dyspareunia, menstrual disorders, urinary tract infections, STIs, and then of course associated with pregnancy complications, increased rates of mental health disorders, and then injuries resulting from physical abuse up to and including violent death. If that is not enough to convince you that screening is indicated, there are preliminary reports that the COVID-19 pandemic and the associated stay-at-home orders, social isolation, financial difficulties have combined to increase rates of IPV in the US and worldwide. We're still waiting on more large-scale studies of this, but initial data does suggest increased IPV calls to domestic violence hotlines and police departments in many states throughout the US. Sorry, you guys, I just got a phone call. I hope that didn't ring here. Great. So also, obviously, this is an equity issue as things like this tend to be. So like in other areas of healthcare, there are certain populations that are disproportionately affected by intimate partner violence. There's often a pretty big gap in our conversations around IPV when it comes to the impact of it on queer and trans communities, despite the fact that, like you can see in this graph, LGBTQ folks are affected by intimate partner violence at least as much as and often more than cishet populations. Across the board, respondents who identify as bisexual have significantly higher lifetime prevalence of rape, physical violence, or stalking by an intimate partner when compared to folks that identify as straight, lesbian, or gay, with over 60% of bisexual women reporting these experiences. Lesbian women and gay men report levels of intimate partner violence and sexual violence that is pretty similar to folks who identify as heterosexual. Even more frustrating is the fact that the NISVS and other common sources on the impact of intimate partner violence completely leave out trans folks. So the majority of data gathering on IPV pretty significantly centers cisgender women, despite the fact that we know trans folks experience a pretty disproportionate degree of other kinds of harassment and violence. This trend does hold true with IPV when you can find this data. So the 2015 US Transgender Survey showed that over half of trans respondents reported experiencing IPV, and those rates are even higher among trans folks of color, people who practice sex work, and folks who are undocumented. And also, as you might expect, you see similar trends for other groups who are systemically marginalized. So non-Hispanic, Native, Black, and mixed race populations are also disproportionately affected by intimate partner violence. This is a trend that holds true for women and for men. We're also, of course, missing folks who don't have access to a phone to participate in these sorts of surveys. So people who are unhoused or incarcerated in similar groups. So knowing all of this, my personal practice is actually to screen all of my patients for IPV, regardless of their age or their gender, because it's fast, it's pretty low harm, and I worry that I'll miss folks who are affected by intimate partner violence but are left out of the USPSTF recommendation. I'll pause there for questions before I move on.
One question I had, Kayla, in thinking about screening everyone and then having the resources to then connect them to to be able to connect them to appropriate resources, do you find that a lot of the resources available are pretty gendered? Like, are the services that I can connect someone to are specific to women rather than an older heterosexual man?
Absolutely, yes. So there are lots of resources for women. There are a number of resources for folks that identify as LGBTQ+, but there are not a lot of resources that I could find for people who are not part of sort of a sexual gender minority community and also aren't women. So it is a big gap. Great. All right, well, let's go back to our case then. So you've gotten to your sort of habit section of your wellness visit, and your patient tells you that she drinks socially, occasionally uses marijuana, identifies as bisexual, and has partners of multiple genders. She's currently dating casually, but she's not in a relationship. So should we screen her for IPV, right? Yes, you're all excellent PCPs. So you recognize that this patient should be screened for intimate partner violence, given her age and her gender, despite not being in a committed relationship. So how would you screen her? Now, we're actually going to do a little bit of a group think here. So feel free to share in the chat or unmute yourselves. But how do you guys ask patients about intimate partner violence? Are there phrases you use? Are there things you try to do or not do when you have these conversations? Annie asks, do you feel safe at home? So does Julie. Open with something like, I like to ask all patients. So a normalizing statement. Thanks, Rebecca. What else? Do you feel safe in your relationship? Yeah. When talking about who they live with or who they have sex with, ask, do you feel safe in the relationship? Other thoughts? Julie does this in the context of PrEP or PEP for HIV exposure, so it's pretty easy to incorporate, harder for other visits. Yeah, so tying it to other parts of your visit that you do routinely. Great. So this is super hard, right? It's like something that I feel a lot of discomfort with in clinic. I have a few stock phrases, but they don't work for everybody. Becca says a combination of open-ended and closed-ended, including phrases like, some people can be hurt or feel like they might be harmed by others. Do you ever feel this way? I feel like that's a great question because it gets pretty broadly at people who are not necessarily in a committed relationship. I love that, Becca. Great. So you guys hit on a lot of this. Patients have been shown to be more likely to disclose intimate partner violence when they're asked about it in an empathetic and open-ended way, and when they are asked just one question or a few short questions. It's also crucial to ask about this when you're alone with your patient, right? So particularly making sure that there's a portion of your visit where their partner isn't in the room, which can sometimes be challenging, but also if possible, having children or other family members step out if your patient is comfortable with it. This probably goes without saying, but partner refusal to leave a room during a visit is definitely a red flag when it comes to some sort of abusive or controlling relationship dynamics. It's also super important to assure patients of the confidentiality of these conversations, but to tell them if there are any sort of mandatory reporting laws in your practice setting. We're obviously also trying to be as destigmatizing as possible with these conversations. So instead of using words like victim or abused or battered, which you'll see all over in the literature, it's more effective to use phrases like hurt or frightened or treated badly, or just to sort of mirror the language that your patients are using. And then obviously we're trying to reduce stigma here. So don't ask patients why they're still with their abusive partner or what they might have done to bring on abuse or other things like that. A note here on reporting. So intimate partner violence doesn't fall under the same mandatory reporting laws as abuse of children or vulnerable adults. But some states do require the mandatory reporting of violence-inflicted injuries or some injuries sustained from IPV specifically. Washington requires reporting of injuries from a weapon. And in general, I'd recommend just knowing the laws wherever you end up practicing. So let us talk about some of the validated screening tools that are recommended by the USPSTF to screen patients. For folks who like to screen cap, this is a good time for that, but I also sent out a summary of these in the email that you guys got last night. I do want to differentiate here between screening, which you guys all know is the recognition of folks who might be at risk in an asymptomatic population from diagnostic evaluation. So these tools were designed to detect IPV in patients that don't have any signs or symptoms of it. I will also give the caveat that, as you might expect, there are pretty limited recommendations of who should be screened. And so these are largely validated to detect IPV in young women. With that said, I do find the language in these to be sort of a helpful framework for asking about IPV in a larger patient population. So the first of these is the HITS tool, which asks patients how often their partner hurt them physically, insults or talks down to them, threatens them, or screams or curses at them. I like this tool because it gets at some of the more sort of emotional or psychological aspects of IPV that can be less prominent when we have these conversations, but I'll note that it doesn't specifically ask about sexual violence at all. The women abuse screening tool is a little bit more in depth. It asks patients more generally about tension and arguments in their relationships, and then goes on to ask if those arguments result in emotional or physical mistreatment, and if patients feel fear in their relationship. And specifically goes on to ask if they have experienced mental, emotional, or sexual abuse by a partner. Let's see. Becca says, do you use the HIT only if you suspect it after you've asked your open-ended questions, or do you use this on everyone? So exactly, so these are validated as screening tools. So these are validated to screen everybody that you're supposed to be screening. So in every young woman that comes to your clinic, these are validated to detect IPV to different degrees. With that said, are these effective questions also to use if you suspect intimate partner violence? I think so, but they're sort of validated for everybody. I am personally a big fan of the HARC, which is a pretty quick screening tool that I think is fairly holistic. So asks patients if they've been humiliated or abused by a partner or an ex-partner, if they're afraid of a current or former partner, if they've had forced sexual activity, and if they've experienced physical harm from a partner. I think this is an interesting one to include. The partner violence scale was specifically validated in an emergency department setting as opposed to a more primary care context, which is where the rest of these were looked at. You'll note that it is pretty limited in scope, so it really just asks about physical violence and then about safety in present or past relationships. There are a bunch of other screening tools that are not specifically recommended by the USPSTF. Two of them are shown here because you'll see them pretty commonly. STAT focuses specifically on physical violence, and SAFE includes some element of safety planning, which I find helpful as well. So I already mentioned this, but these are pretty limited in scope, right? So they are pretty specific in general for these various types of intimate partner violence, but as you'll have noticed on all those slides, they all lack sensitivity in a pretty significant way. And partly that's because they often ask about specific kinds of violence and fail to screen for more subtle forms of abuse between intimate partners. I will mention one more time that these are screening tools and that they're designed to detect IPV in women and likely largely cisgender women in heterosexual relationships. And because of this, they're not a substitute for being great providers who listen in an open, empathetic, patient way. So other options to screening tools are just a single open-ended question, which has been shown to detect IPV in a primary care setting if done in a routine way. It's crucial if you're trying to do this for screening to ask this routinely of all of your patients, for example, at your wellness visits. And I think this probably goes without saying, but there's data to back up the idea that if you do this in a non-judgmental way that prioritizes patient autonomy, it'll be more effective. I'll show you some example questions that I've borrowed from a variety of places as kind of a representative sample. I think of these in kind of three categories. So the first is broad questions about safety and physical or threatened violence. This starts with the classic, do you feel safe in your relationship? Which I think is what a lot of people ask and is what I've historically asked in my clinic visits. But others ask more specifically about whether patients have been hurt or threatened in a relationship. I particularly like this question that asks if patients have been treated badly and sort of allows them to contextualize what it means for them. This next set of questions is more general questions about conflicts in a relationship. So asking what happens when patients disagree with their partner or when they fight at home. And I think that these ones that have normalizing statements like, we all get into arguments, or every couple has conflicts, and then goes on to ask how those things are handled in your patient's relationship, are particularly helpful. I also like this phrase, do you ever feel afraid of your partner? And this last set of questions are more specific about other forms of violence, intimidation, or coercion. Obviously, these are maybe not as good as a single screening question, but are something that you could pair with one of the more general questions to get at some of these more specific ideas. And then obviously, if patients are answering yes to any of these questions, your next steps are to explore further in an open and non-judgmental way. So the way that I do this currently in my primary care practice, and I think everybody does this differently, is to ask a single open-ended question of all my patients, regardless of age and gender. And I do that during the sort of like diet, exercise, things to keep you healthy part of my wellness visit. It's part of my wellness visit template, and I introduce it by telling patients that I'm going to ask them a few questions about keeping them safe, and then go on to ask about intimate partner violence, as well as like guns in the home and a few other different safety issues. I do think I'm going to play around with using one of these short form screening tools in the inpatient setting with some of my patients, and I made a dot phrase for this that I'll share with you guys at the end. All right, before I move on, any other questions about the screening tools or language? All right, well, let's return to our case then. So you ask your patient if she's ever been in a relationship where she was hurt or threatened, and she tells you that her ex-boyfriend sometimes used to throw things at her and yell when he was angry, and that she ended the relationship after he hit her 2 months ago, giving her a black eye. While they're no longer together, he sometimes shows up at her house uninvited, which makes her feel pretty scared, and he calls her pretty often, leaving angry voice messages and sends her a lot of explicit texts. So you used a screening tool or an open-ended question. You've done a great job as the empathetic provider that you are, and you've discovered that your patient is experiencing IPV. So what now? Ooh, the VA asks any suggestion on what to do when you suspect your patient is being abusive to their partner. So this is a whole other big question. There is actually tons of data on this. There are not any good effective interventions. Some of the same questions are helpful, and there are some folks who try to do counseling for people who are perpetrators of abuse. From what I could tell from the literature, none of those interventions are super effective currently, but I do still think it's something that it's worth connecting your patient to some of these same resources like social work, counseling, et cetera, to get more support with this if they're interested. And then of course, obviously, if you're really worried that your patient is committing some sort of violence that's dangerous to somebody else, making sure to get the appropriate people involved. That's a super good question, VA. Thanks. Okay, so next steps here are obviously a sort of a complex question, and it's going to require the help of a lot of people that are not just you. But these are some next steps that are also validated in the literature to help reduce the risk of folks experiencing IPV and to help survivors feel supported. This unsurprisingly sounds like a lot of other parts of trauma-informed care. So when survivors of IPV are surveyed, they report that they would like to have supportive listening, empathetic interaction, and really sort of an affirmation and validation that the violence they've experienced is not their fault. They also really value the ability to progress at their own pace. And that makes sense, right? Like people who are experiencing IPV have sort of chronically had their autonomy withheld in a lot of contexts. And so it's really important to avoid pressuring them to disclose or leave the relationship or press charges, and really engage in shared decision-making with these patients. With that said, the vast majority of patients experiencing IPV are not in imminent danger, but some of them are, and IPV can absolutely result in death. So it is important to screen for physical safety and to safety plan with patients who are at risk. There are a bunch of tools to do this. Some of them are pretty lengthy and clunky, like this one that I've shown here, which is like multiple pages long. I personally like this shorter tool, which I think is easier to implement in clinic. So this asks patients if physical violence has increased in frequency, if their partner has ever threatened them with a weapon or used a weapon against them, if they think their partner is capable of killing them, if their partner has ever tried to choke them, and if their partner is constantly jealous of them. Positive answers to 2 or more of these questions indicate an increased risk of serious injury or death at the hands of an intimate partner. And I do want to note that choking or strangulation is specifically mentioned in most of these tools because it's been shown to be a particularly high risk feature and is something that is important to ask these patients about. In general, it's important to ask patients in an open-ended way about their current level of fear in their relationship and what they think their safety needs are. And then if folks have safety concerns or you have concerns based on the sort of safety screening, to help them form and document a safety plan if they're open to it. So that can include information about places to go in an emergency and ways to reach out for help, as well as more concrete things like helping them form an emergency kit with some important items if they need to leave home quickly. If patients are open to intervention, then you can go on and connect them with further support. It's helpful if you can to carefully document these conversations, both for your future clinical use, as well as if patients decide to pursue legal action. But this is something that you should only do with your patient's consent, because it can also be a safety issue. Partners sometimes have access to patients' electronic medical records and things like that. So ask your patients if they're okay with you writing this on the chart. And I sometimes will actually write in the sticky note if I want people, or a telephone note per MAC, somewhere that is not discoverable in eCare. This is also the time to refer people to support services, both within your clinical context as well as in the larger community. And I do have a list of these for you guys at the end of this talk. I also want us to recognize that in our counseling, leaving or attempting to leave a violent relationship often escalates violence, and it can be a particularly dangerous time for our patients. So if we're giving information on shelters or legal aid or other sorts of resources, it's important to do that in a safe way. So that can be on a small piece of paper that they can keep somewhere discreet, or entered into their phone under some sort of code name, things like that. It can also be helpful to provide people access to a safe phone line that they can use if that's available in your clinical setting, because perpetrators of this kind of violence will often monitor internet use, cell phone use, things like that. So we're going to practice this a little bit, but before I move on, any questions?
I have a question. Does each specific clinic have a set of resources that we can refer patients to?
Not that I know of. The resources that I'll share with you are resources sort of either nationally or in Washington or King County specifically. It may be that some of our clinics have a specific list of resources. Mine does not, that I know of. But of course, we all do have wonderful social work support in all of our clinical contexts. Let's see, Max says at Roosevelt, he just runs to Jan. And I think that is often a place that I go in my clinic, is to our social work team to ask for what support I can give patients. Yeah. All right, so I want to validate that these are super difficult conversations to have with patients, but they also do get easier with practice. So we're going to break into some small groups and work through 3 cases together. You all should have gotten an email with a document with these cases and questions, and then a second document that summarizes some of these tools we just talked about for reference. I will encourage you to actually practice saying this stuff out loud. I know that we hate role play, but I think it is how you get better at having these conversations. With that said, if this discussion feels triggering for you at all, or you're not comfortable having it, feel free to keep your camera off, go take 15 minutes to yourself, and maybe think about practicing these out loud to yourself or your stuffed animal or something like that later. So let's, if we can, send our folks to our breakout rooms, and then I will see you guys in about 15 minutes to wrap up.
Kayla, I'm just gonna drop the file into the chat just in case.
That is perfect. I was just gonna do it, but you beat me to it.
Nina, it's too late.
It's too late. Oh,
Yep.
if I send a chat, will it be broadcasted or no?
It'll just go to the
Send
three
the
of us.
chat. It's only gonna go to the 4 of us or the 3 of us in here. You gotta do it before
Oh,
break.
that's silly. Okay.
Okay. Luckily, got email to him yesterday. I was like composing an email to you to have it sent out,
Of
and then I
course.
got your email
Of
yesterday. I was
course.
like, oh my God.
No worries at all. I think, yeah, I
It's
should
fine.
have
I made
it
it.
then. Kayla, can you remind me where your clinic is?
I'm at Belltown.
At Belton. Okay. Yeah, Rigo, one of our interns, had a great question
Mhm.
about whether or not these screening, like there's any sort of screening in Epic itself.
Mhm.
And I didn't know this
Oh.
specifically, but there is.
Mhm.
If you're like in the rooming tab for a patient and then you click on history, like right under where they ask about like transportation needs, food insecurity, and social
Mhm.
connections and stuff, there's a couple questions for IPV, which is something that is very, like, I didn't know that that was.
I didn't
in
know
our
that
clinic.
either. I
Yeah,
clearly don't look at the rooming tab very often.
Yeah.
on my visits.
I mean, like, let's be honest.
All right, guys, thank you for participating in that. I'm hoping that after your time in your groups, you feel a little bit more comfortable with this last objective, which is practicing some of this language to use when screening patients for intimate partner violence. Otherwise, hopefully today you've had a chance to define IPV and to maybe broaden your illness scripts a little bit for folks who are affected by this problem. And then you have some hopefully recognizing some validated screening tools for intimate partner violence. I want to share with you guys some specific IPV related dot phrases that I use in my clinical practice to prompt me on screening questions, safety assessments, and then resources to give these patients. You're welcome to copy these from my smart phrase manager if you search Sheridan, Kayla, and adapt them for your own use. I did also learn while you guys were in your breakout rooms that Epic actually does have a prompt for these questions in its rooming section. So if you click through all of those various rooming questions, there is a section prompting you to ask about IPV that includes the hit screen. This is also a sample list of resources. Again, for those of you who like to screen cap, this is also in that Epic Smart Phrase and is on the document that I sent out. And then because there's always one person who wants to look up the references, here is that slide. With that said, thank you guys so much for your attention. Thank you to the R3s and the clinician educator track for giving feedback on this talk and listening to me talk about it probably too much. And what questions can I answer for you guys? Thanks, Roxanne. All right. Well, thank you guys so much. I will stop sharing my screen if I can here and hand it off to James.